Alrighty, I know it's getting a little bit late, so we are running a little bit behind. So the next session is going to be moderated by Dr. Chanchal Pal. You've heard about her, but she does need a little bit of repeating because she has been working so hard. She's a senior consultant in ENT at Indraprastha Apollo Hospital. She has more than 35 years of experience, past president of the IMA South Delhi branch, and Lions Club of Delhi in Alaknanda. And she's president of Ear Care Foundation of India, and she has her pride is in planting trees, and which she has done more than 5,000 of them. And she has written books, and her interests are in, during her presentation, you probably heard about her interest in FESS. So Dr. Chanchal, please start this next session.
Thank you, Dr. Indrapal. So our first speaker is Dr. Tapaswini Pradhan. I'll just give a brief introduction. Dr. Sudhir Tyagi has not come, so we'll start with Dr. Tapaswini. And Dr. Tapaswini Pradhan is working as a head and onco surgeon at Apollo Indraprastha Hospital. She has been trained as a head and neck surgeon from the AIIMS. This is her field where she's been trained, New Delhi. And also before her at Pittsburgh Penn University, USA for robotic and skull-based surgery. And at University of Genova for laser surgery, Italy. And apart from that, Tapaswini is very, very active in patients and doctors' education. She has won what she calls Tapaswini's Corner, and where she takes interview every week. That includes medical subject for public as well as doctors, and even for spiritual subjects like what we had with Swamiji, she had with Brahma Kumari and other. So with these words, may I request Dr. Tapaswini Pradhan to present her subject, Changing Landscapes of Head and Neck Cancer in India. Dr. Tapaswini.
Good afternoon, namaskar, and Om Shanti. Thank you so much, Dr. Chanchal, for the introduction. I bring greetings from one of the big corporate institutions of India, and that's the Apollo Group. So I'm going to talk about what's changed over the years in head and neck cancers. So if you look at the incidence in India, in the males, head and neck cancer is the most common, while amongst the females, it is the fourth most common cancer. So that's the garden variety of head and neck cancers that we get to see in our country. Tongue, the lip, oropharynx. That's a huge jaw tumor. Entire lip involved. Lip, buccal mucosa, alveolus involved. And the huge spectra. So I'll show you as to how we deal with these cancers. Now, it's a challenging subject because head and neck is an anatomically very complex, and you'll realize it has got lot of anatomical areas which have their own subunits. Like it's the nose and the paranasal sinuses. You'll have the ethmoids, you'll have the nose, you have the various sinuses, and cancers originating in each of these areas would be biologically very diverse and very different. So each of the subsite in the head and neck behaves very differently. And it's anatomically also quite delicate and quite intricate. The second is it lodges a lot of important structures like speech, swallowing, facial dynamics, olfactory sensations. So there are so many special functions which are lodged in this particular area. So you have both static and dynamic structures, the facial, emotional expressions which come from the facial areas. And the challenge is, of course, how does one restore the anatomy, the form, and the functionality? So that's what is tricky, and that's what keeps us going. In India, most of our patients present in an advanced stage, 70 to 80% of them, unfortunately, come to us when they are really advanced. Most of the factors which we attribute is, one is, of course, ignorance. The second is fear of disfigurement. And a lot of people also resort to a lot of alternative medication like homeopathy, Ayurveda, and so many others, which I don't want to describe, yes, but they do use a lot of alternative treatments. A social taboo to discuss that the patient or an individual has cancer, people consider it as a social taboo. A lot of financial issues because it's a draining exercise, and a lot of places in our country lack the infrastructure to handle cancer patients. So as a result, we would see, ironically, even though this area is so much amenable to visual inspection, we still have people coming in advanced stage. Let's look at this plethora of presentation which happens as precancerous lesions. It's important here to everyone because we often get to see in our clinical practice. So oral submucosal fibrosis, very common in our country because of consumption of areca nut, which we popularly call as supari and pan masala. So oral submucosal fibrosis, you'll realize around 7% on an average do convert into squamous cell carcinomas. Then you have homogeneous leukoplakias, which can happen in any part of the head and neck, subjected to tobacco exposure. So homogeneous leukoplakia has a 0.5 to 17%. But if you look at erythroleukoplakia, it's got a very high incidence. And if you have speckled leukoplakic patches, one must biopsy these areas, and especially at certain anatomical subsites like the tongue. Leukoplakias are, of course, have a high chance. Leukoplakias on the tongue, 90% conversion rate into cancers. And then you have something called lichen planus. Lichen planus has a very low incidence, but erosive lichen planus, yes, has a very high incidence of conversion. And this is an entity which is called a proliferative verrucous lesion, almost 100% squamous cell carcinoma conversion. So we get to see them in our clinical practice day in, day out. Now, certain benign causes which may be confused. Now, if you see a picture on the left side, this is something which is benign. This is edema on the vocal cords, which may be traumatic. But the one that you see on the right side is suspicious, but may not be. But the one below is highly suspicious of malignancy. Now, this is an NBI picture. What has come into our array is NBI, and how has it been able to rescue is because of the use of blue and green light, we are able to discern an area. See how a picture changes the moment it is an NBI light. So the green and the blue light help us to appreciate the vascular structure. And whenever you have real tortuous serpentinous vascular area, these are the areas which are suspicious and need to be biopsied. So NBI has actually helped us to discern the areas where you should put your biopsies from. Otherwise, there are many anatomical areas where you can have huge extensive lesions but may not know where to biopsy to get an answer. So NBI has come to our rescue. Now let's look at certain other clinical scenarios. This is a poor orodental hygiene, a very common etiological factor for oral cancers. So a small penetrating ulcer which has just started appearing, and see after a couple of months, conversion into frank malignancy. Now on the lip, a lip lesion, a lip lesion, this is innocuous. This we often see as a stress-induced abscess ulcer. But if you have a lesion, why is it getting on? Escaping. So this is definitely a lip ulcer, which is benign. It is not benign, it is malignancy. If you look at a lesion here on the lateral border of the tongue, it is giving you some suspicious feeling that this probably has or is harboring some cancer, but this is definitely a frank malignancy. This is an oropharyngeal lesion, looking as proliferative. Many of us confuse as tubercular, but this is something which is an HPV-induced cancer. Now, what is the reason why we should be looking at all this and all of us should be aware is because if you catch your patients young in the early stage of the disease, a survival curve, you see a survival figure of almost around 94%. But as the disease advances, the survival curve dramatically falls close to around 58%. So it is important for all of us to know how these lesions look like. The treatment is a multi-pronged treatment. You will have a lot of specialities involved. You have an oncosurgeon primarily because most of the head and neck cancers are surgical. They are to be subjected to surgery. Since patients present in an advanced stage, radiation comes in handy as an adjuvant treatment. Onco-reconstruction, of course, head and neck is always married to an onco-reconstruction because any part which you remove has to be reconstructed back. And radiation oncologist, a medical oncologist, and of course, at the end of the day, the patient asks us what would be his quality of life. So after all the interventions that we do, the most important question, because if he is to survive, he or she would not like to survive if you don't give him a good quality of life. So how do we do that? So these are the different functions that the head and neck area actually has. So if you look at the ladder, the most important that we look at is how are we going to restore his speech, swallowing, mastication, and the last thing which comes in is the cosmesis, which in fact for the patient is the most important thing. But for us, the other three are more important. Now, this is what has revolutionized the results of head and neck cancer surgeries, and that's what is called a free flap. So free flap is when you harvest. I'll show you how it is done. This is one of the free flaps which we have taken it from the radial forearm. This is from the forearm which has been harvested along with its blood vessels, and then the anastomosis of the blood vessels of the donor is done at the recipient site, which is the patient with the neck vessels, and this is all microscopic. So a flap harvested from the thigh or from the forearm or from the leg is moved up into the head and neck, anastomosed to the blood vessels there, and it gives a beautiful cosmetic result. So nature has given us a lot of spare parts, and that's where we have a lot of gratitude to the Almighty. And you'll find you can take these flaps from so many anatomical areas in the body. So the most commonly used is the pectoralis major. Then you can take the rectus abdominis flap, forearm flaps, and then we have flaps from the thigh, which is the anterolateral thigh flap, fibula, the bone flaps, and the bone flaps being used primarily to make the jaw bones. And you can do a beautiful origami of these flaps and structure and restructure all these flaps to make to the contour of the head and neck area. Quick examples of how we've been doing buccal mucosa. This is a classic picture which I have shown you. And this is very true of our country, where you have extensive lesions, fungating lesions, well-educated people, but still you have, because they resort to alternate therapies because of the fear of disfigurement. And this is how the tumor excision has been done. This is how the tumor looks like. See, look at the extent of resection and the amount of the defect which is formed. So you definitely cannot do with one flap. So one, we do a plating, mandibular plating, that's just to keep the jaw aligned. So the flap below that you are seeing has been harvested from the chest, and the flap above is being harvested from the thigh. And this is the anterolateral thigh flap. This is getting ready, and this is how the final result of the patient looks like after he has undergone radiation. Another example, classic example of lesion which is involved the buccal mucosa and the angle of the mouth, commissure. This is the radial forearm flap which is being harvested, And this is how it has been contoured. This is how the patient initially looked like, and he's undergoing a secondary reanimation. And this is his result immediately post-op. This was after he had received radiation, and this is how he looked like finally. This is after an year of the entire treatment. So this is the beautiful aspect of head and neck with reconstruction, where you can do facial reanimation to put such young patients back into the society. Now, in the tongue, the most important thing about the tongue is how does one get the pliability of the tongue? It's a highly muscular structure. You have to have the speech of the patient at least that coherent enough that everybody else understands it. So I'll give you a classic example of a journalist whose work, he works with one of the topmost television industry, and this is where how we had resected the tongue, and post-resection, can I do it from there? Because I don't know why it skips. Okay, so we'll go on to this. This is a huge jaw tumor. This is an international patient that we had. Why did he reach to this particular stage? Is because there was no plastic reconstructive surgeon to make a complete jaw. So how did we do it? And this was a jaw-to-jaw resection, except for the TM joint. On both the sides, the entire jaw was resected. So this is how the flap has been harvested. This is the fibula flap, but the flap is a straight bone. Fibula is a straight bone. So how does one contour it to the jaw? You make multiple fractures, which are called osteotomies, and make it into the shape of a jaw. And this is how the radiological picture of his jaw looked like. And you have platings done. So that is how the various osteotomy sites are made stable. This is how he looked like in the immediate post-op. And if you see, this is again a picture radiologically after the healing. This is another patient who had the same tumor. He was smart enough. So this was the fibula flap. And see, he got his osseointegrated implants done on the fibula and the teeth replaced. So a perfect dentition where a complete jaw has been removed. So that's the beauty of free flaps, where you can also rehabilitate them through a good dentition. This is another girl from outstation, from out of country. This is, again, you can see this is a jaw tumor which is extensively destroyed. And we had done this with a cancellous bone that was the iliac crest, pelvic bone. And this is how she had a deficit in the dental area. And then finally, she got her dentition planted. So unless you have a jaw which is replaced by a bone, you cannot do these sorts of rehabilitation. So the jaw bones have to be bone, as the principle of plastic is any tissue that you remove. So you have to, like has to be replaced with a like tissue. If it is a bone, it has to be replaced with a bony tissue. So this is the result. Now, lip is something which is very, very difficult to be reconstructed. And we do understand what is the importance of having a beautifully reconstructed, because of the various expressions which come with the movement of the lip, and also most important is oral competence. Because after the resection of the lip, especially the lower lip, people can have drooling of saliva, which is so, patients get so depressed because they become aloof from the society and they are not able to put themselves back. How do we do it? And this is one classic example of our upper lip tumor, which is predominantly a sun-induced exposure, which has produced this upper lip cancer. Imagine almost the entire upper lip resected. How does one reconstruct? So this is how we have used various triangles in the face, which are called the Burroughs triangle, how the advancement has been done. How does one get this red part of the lip? That's the beauty of reconstruction. See how much of movement, and we have taken a lot of tissue from the lower lip also, which you cannot realize. And this is the beauty of a beautiful constructed upper lip. See, nobody can say that he had lost so much of the upper lip. And this is the final result after he had received radiation. Now, when you have a lower lip, full, complete, almost a complete lower lip resection, see, just 1/4 left on either sides. But this can be beautifully again done. There is a lot of soft tissue which can be mobilized in the facial area. You can use them, and this is how the result was after he was, this is what we call as carapanzic flap. Now, larynx is something where a lot of patients do not want to undergo surgery because of loss of voice. But that's the story which was there in the past. This is a post-cricoid carcinoma where the resection has been done and the reconstruction done. And now we look at the final result of this patient. This is the voice prosthesis. A lot of centers do not use, but we use these voice prostheses. They are either a Swedish make or they are from the US make, InHealth or the Blom Singer, or we have the Provox. And the quality of voice that we get. Can somebody run the video from there? I would love some people to listen to this voice. So this is a hands-free speech that we use. So if you just close your eyes and listen to these voices, so you would never think that they have no vocal cords. So that's the beauty of putting voice prostheses. So patients have to be convinced that voice loss should never be a deterrent. We have beautiful ways to rehabilitate the voice. Recurrent cancers are often a question mark whether you should operate or not operate, but then it is not a very sad scenario, but your choice of treatment has to be really, really judicious. So this is one lesion. This is one patient who was refused from a lot of centers, had buccal mucosa carcinoma which had been radiated but failed. And look at the lesion and such a pitiable sight, and she was refused. But we did attempt, and this was the extent of resection that she had. So we had used what is called the anterolateral thigh flap, and this is how she looked. Beautiful, because we could put her back into her normal life, and she was back into work, and she's still surviving. And I'm so happy that at least we took the right decision to put her back, and the family members are happy. Now, recurrences can happen good number of times, and we all know that surgery scores over any other treatment. So this is another patient who has undergone almost around 5 surgeries. From 2008 to 2023, he has undergone 5 different surgeries. He has had cancer at 5 different anatomical sites. So what do I want to show is that please do not refuse your patients even when they have multiple cancers, or see, he is showing the different scarred areas from where we have taken the flaps. But God has been very kind. He continues to live. What has changed in our neck dissections? So from big incisions, we have moved to very small incisions, and that too not compromising on our oncological clearance. These were the various incisions which were being used in the past. The laser pointer is not working. So these were the various incisions. Now if you look at the incision that we give, that is at your right corner, it's only a 5 to 6 centimeter incision that you give. Very cosmetic, because you take it on the neck skin creases and you can do a complete neck dissection. Now, what should be the extent of neck dissection? That too also has changed over the time. Earlier, any neck which had a node, all that we were doing was a radical neck dissection. Now we have moved on to something which is called a functional neck dissection. And now we have still further moved on doing a selective neck dissection. That's because we have understood the different oncological principles and also how had the tumor behavior different in the different anatomical sites. So radical neck dissection has almost become the thing of the past, and the various problems which most most of our patients had in the past, and majorly it was a shoulder dysfunction. Now we don't do any R&Ds. This is how the shoulders would look like after a radical neck dissection. And if one was to do a radical neck dissection on both the sides, unfortunately, you will not have your patient surviving. They do succumb because of massive brain edema, which the patient develops post these treatment. So MND versus R&D, we have realized that if you do a modification on your radical neck dissection, you almost have a very good oncological result. And this is how a patient with a bilateral neck but a modified neck dissection would look like in the postoperative period. Just a brief on how technology has added on to our armamentarium in our surgical techniques is, one is the invention with laser. This has scored a lot when we talk about our vocal cord carcinomas. Minimal hemorrhage, very short hospital stay, quick recovery, patient gets back to his work very fast. What we used to do for vocal cord carcinomas in the past was radiation, and that used to take 7 weeks of his time with certain problems which used to be lingering throughout his life. So laser has made a lot of change. This is a small lesion you can see on the surface of the vocal cord. We are trying to inspect this particular lesion. This is a tumor. This is a malignancy. That white patch that you see is a malignancy. So what we did was a laser cordectomy. You can see the beam of the laser. You mark the margins, and this is how the beam is cutting. And laser is such a beautiful, beautiful tool that you can actually make out the tissue planes, whether you are at the right depth or not, and see there's barely any bleeding. And the vocal cord has recovered so beautifully. So that's the beauty of laser. The other thing which is added is the robotic surgery, and especially in those areas which were not amenable to our surgical resection. And one of the site is the base tongue area. So see, this is the base tongue. In the past, if we were to do resection of the base tongue, we would have to split the lip and also the mandible. Now this, with robotic surgery, you don't have to do these procedures. You don't have to do a mandibulotomy or even a lip split. So with the robotic arms, you can beautifully resect the base tongue lesion with very good margins and leave this lesion, leave this defect raw. It heals off on its own. So that's the resected specimen, which goes for a frozen section analysis to give us a convincing information on the depth. So that's how the defect looks like. So mandibulotomy avoided, so swallowing becomes better, no tracheostomy required, hardly any blood loss, little pain, and patient goes back. So the recovery is fast. Well, that's the end of my talk, and this is a beautiful message which comes from patients. My life isn't perfect, but I'm thankful for whatever I have. I think that's the gratitude which we all should have. And so the ship has sailed from its side, but it doesn't mean that my journey ends. It simply means that the river has just bent. Well, this is the corner which I run. This is called the Dr. Tapaswini's Corner, which was given by the Government of India for the Prime Minister's program. And since I was selected, the corner was in my name. You can view this corner on the Instagram. I'm also loading them on the YouTube. So I have a lot of experts speaking on cancer from all over India and a lot of survivors from real top professions. Also, now the part 2 has a lot of information on spirituality. We've done on beauty with brains. Now we're going to do on yoga and a lot of important issues from the society, from the social point of view. Thank you so much. And that's my plastic surgeon, Dr. Sandeep Mehta. And I'm really, really grateful to all of you for giving me a patient hearing. Thanks a lot.
Thank you, Dr. Tapaswini. I will use the same word which you have been using frequently, beautiful. Your presentation was as beautiful as you are. And I want to emphasize Dr. Bhavani now onwards is going to be women's power, because all over we have women. After Kenya presentation and after evening women's forum also. So we have left no option for question because you was so elaborate in your presentation. Anybody who wants to discuss can go ahead when she is always available throughout the day. So we move on to next another beautiful speaker. May I invite Dr. Ranju Singh, please. She is Director Professor of Lady Hardinge Medical College and Associated Hospital. Dr. Ranju has established the Delhi chapter of IAPA and currently President of IAPA Delhi chapter. She had been Vice President of the chapter of ISA of anesthesia. She has got several awards. I'll just mention few of them. Academic Excellent Award in Medical Sciences in 2023 by Delhi University. Public Awareness Award by CPR by ISA. Honorary Fellowship of Indian College of Anesthesiology Award. ISA Delhi President Appreciation Award. ISA Diligent Award 2022. Award of Excellence by Anesthesia Society of India. COVID Warrior Award also. She has more than 250 presentations and lectures in national and international conferences, more than 70 national and international journals. She has written her publication and also written chapters in the books. So with that, I do invite Director Professor of Lady Hardinge Medical College, Dr. Ranju Singh, please. So go ahead with your talk on recent advances in pediatric anesthesia. Dr. Ranju Singh.
Thank you so much for that very kind introduction. I'm thankful to RP for giving me this opportunity to come to this forum and speak about a topic which is so close to my heart. Any anesthesiologists in the house, please? Yes, one. Good to see that. So, yeah, rest are surgeons, so that makes life even more interesting. So, Right. Good to see you, ma'am. So, anesthesia per se is a little bit of a niche topic, and pediatric anesthesia is even more so. So, for all the non-anesthesiologists in the house, I'll try to keep the discussion less complicated and more practical so that you can not only enjoy it, but take back a message and try and understand what pediatric anesthesia is all about. My major practice is pediatric anesthesia. The remaining part of the time I do mostly obstetrics, and I come from a very high volume center in Delhi, which is the Kalavati Saran Children's Hospital. So we've moved a long way. All those lovely presentations which your previous speaker has shown you, especially dealing with the airway, head and neck, larynx, couldn't have been possible without the help of an anesthesiologist. So how do you get control of the airway? How do you manage their anesthesia? How do you manage that airway? You couldn't have done it without an anesthesiologist. So we've moved a long way from what you see on the screen on the left-hand side. Can we have slightly dimmer lights, please? So from what you see on the left hand of the screen to what you see on the right side, like she ended with robotic surgery, we've really come a long way. Anesthesiology has not only made a lot of strides, but it's also become extremely safe with improvements in patient safety and a notable increase in mortality. When anesthesia and surgery started, surgery meant sure shot death, and anesthesia was not there to save the patients. But we've really come a long way from that. And this decrease in mortality and increase in safety is mostly attributable to the advancement of medications, procedures, and equipment. You saw the lecture, you saw how beautifully laser has worked in removing all those lesions. It's advancement of equipment in all fields of medicine which has contributed to patient safety. And I aim in this forum to highlight the scientifically proved advances in the last 10 years in the field of pediatric anesthesia. And with that aim, the learning objectives of my talk are to highlight the critical component of ERAS in pediatric patients, such as patient counseling, fasting, and pharmacological premedication, to emphasize the importance of what we now know as para-oxygenation in addition to pre-oxygenation, and to discuss improvements in equipment and resuscitation protocols. So what is ERAS? Enhanced recovery after surgery is what is being practiced by surgeons today. It improves patient outcomes and allows your patients, as she said, to be back into the society as early as possible. And this concentrates on all facets of the perioperative care, including preoperative, intraoperative, and postoperative period. Now, in pediatric anesthesia, we are always concerned about children being fasted preoperatively. And we have been fasting them since time immemorial for long periods because we fear that there will be an aspiration preoperatively or on the table when we induce anesthesia. But latest research and all that equipment and scientific research and MRI studies have now shown that we needn't fast the pediatric patients for such long durations of time prior to their anesthesia and surgery. And ERAS has brought this into a protocolized focus. We now keep our fasting patients only for 1 hour. We allow them clear fluids for as long as just 1 hour before surgery. And this is a major advancement which has taken place in the last year or so. Even breast milk can be taken for up to 3 hours before surgery. So we are way past the era of keeping them fasting overnight so that you have hungry, crying, and fasting children early in the morning. This has been endorsed by various national and international society and has come into literature and has reached a consensus. What has brought about this change? Ultrasonography has really revolutionized this preoperative fasting practice in children. Regular use of evaluation of gastric contents by the bedside ultrasound is now become a part of routine pediatric anesthesia practice, given the fact that it's non-invasive, bedside friendly, and very straightforward for implementation and identification of those patients who do not have complete fasting preoperatively. We can identify, we needn't fast all the patients for long hours, and use of this ultrasound preoperatively now as a routine practice in all centers allows us to fast patients for the minimum duration preoperatively. What about pharmacological premedication? Now, people are scared of giving premedication to children because they're not very sure how they'll behave, how their airway will behave, what will happen to their oxygenation. But over a period of time, consensus has been reached that children need anxiolysis as much as the adults do. Yes, there is a place for non-pharmacological intervention. This has to be done before and alongside pharmacological intervention. But now there is consensus recently that you must give premedication to all children, particularly when they're out of the infant age group. That is when the separation anxiety sets in. And sedative premedication with the help of pharmacology is definitely recommended when alternative techniques have failed, when there is failure of when you are anticipating that the induction of the child will be stormy, those who need multiple operative procedures, those who've had a previous traumatic perioperative experience, and those who have special needs, such as autistic children who will have difficulty in cooperating with the physicians. What should you give as a premedication? We've narrowed down the spectrum to drugs like midazolam, ketamine, and clonidine, but the new kid on the block is dexmedetomidine, which is a selective alpha-2 agonist, and it provides beautiful analgesia, sedation, and natural sleep with no respiratory depression. It's used in various doses, but the mean dose usually prescribed for children preoperatively is 2 microgram per kg. And the latest in this edition of the armamentarium is that we can give this drug by inhalational route like we do nebulization for all other routes. Now, I think we're skipping a slide here. Okay, so what's new in the airway management? Now we've had a child who's come, who's not fasting, who's been pre-medicated well. What are we going to do with him on the table? Is there anything new? Yes, there is. Now, in this paper, which was recently published in the British Journal of Anesthesia just 2 years back, it is known as the Nectarine study. It showed that there is a higher incidence of difficult airway in children less than 60 weeks post-conceptional age, leading to severe hypoxemia even in today's date. In spite of all the advances in armamentarium of the anesthesiologist, we still have a mortality and morbidity related to hypoxemia when we are dealing with the airway of small children. So what's the way out? We have realized that we need to do what is known as para-oxygenation. You are well aware that children have higher oxygen demands and lesser oxygen stores, so they don't behave so well during the apnea which we produce for induction of anesthesia as in adults. They will have severe hypoxemia with the onset of apnea. Moreover, you can't pre-oxygenate the children. You can't force down a mask on a child who's anyway crying and uncooperative on table. So what do? We do what is known as para-oxygenation, which means that we give oxygenation simultaneously while we are inducing anesthesia. And with this technique, we've brought up the safe apnea period for as long as 8 minutes from 2 to 3 minutes in children. What is the new equipment that we are using in airway? Video laryngoscopes have revolutionized the management of airway in children. We were so scared in handling children who were syndromic, children who had airway abnormalities. But with the use of video laryngoscopes, it has become really simple to handle the airway. In this multicentric trial published recently, which has now inferred with certainty that the use of video laryngoscopes as a routine, all of you who are surgeons are used to seeing us use laryngoscopes for maintenance of the airway. We've moved away from there. We now use video laryngoscope as a primary device because it increases the success rate and reduces complication in anesthetized children. Microcuff tube is another new thing which has happened. Now, traditionally, we never used cuff tubes in children. We were so scared of subglottic stenosis. But newer studies have shown that it's the rima glottidis, which is the narrowest part of the larynx, and the newly designed microcuff tubes are beneficial in adults as well as in children. They are thin cuffed, they do not have so much of pressure, their shape is such that they produce a change in the cuff diameter is very thin, and there is a change in the shape of the cuff, which means that it does not produce any change in the edema pattern of the larynx. Appropriate size endotracheal tubes are required, and USG is now emerging as the means to accurately measure the endotracheal tube size in children. I have a fear that a different presentation has been loaded because this is not the final presentation, Dr. Indapal. I don't know, because the videos are not running and it was in a later version. So I don't know if we can do anything about it. The videos are all missing, which was in a later presentation. Anyway, so will you give me a second while we figure this out? Can you, this is not the final presentation. And yeah, I think so, because I don't know what's been copied. Yes. Because this has got missing stuff. This is not the same presentation. No, this has got missing slides in it. So, no, this is not the presentation. Can you go back to the desktop where you've copied this from? There are two presentations there with recent advances. I don't know which one is running.
Yeah, there are two.
Can I give you my pen drive to run it? Because something's gone wrong here. And yes, see, one has been copied at the, can I give you, if you give me a minute to. Right. So a couple of slides were missing. Initially, I thought that maybe my dementia has taken over and I've missed a few. But I realized that an older version probably has got copied. Can you run it from this only? Yes, please move ahead. I don't know. There's something, maybe a file has got corrupted. Okay. Right. No, this is the older. Anyway, is this the only presentation which has got loaded? Yeah. Okay, fine. Okay, we'll carry on this. Right. So can you? That's all right. We were talking about micro cuff tubes, and we were talking about new in airway equipment, which was use of what we know as supraglottic devices. Now, supraglottic devices are devices which sit on the glottic opening and really do not, you didn't enter the glottic opening for maintaining the airway. We had started with adult devices. These days, smaller and smaller devices, which are very accurate to the anatomy of neonates, have come into the market, and it's made us very, very safe. We don't really need to mess with the airway because we have supraglottic devices to help us work around. So this slide is empty, but never mind. Another big area where changes have come in the recent past is in the field of regional anesthesia. Regional anesthesia in children has seen new horizons because we've replaced the central neuraxial block, which you all grew up with, epidurals and spinals, with what is known as the facial plane blocks. So you have erector spinae plane blocks, paravertebral blocks. What we now do is under vision with the ultrasound, introduce local anesthetics into the muscle planes. The plane between the muscles is amenable to spread of local anesthetic. It has made anesthesia, regional anesthesia, extremely safe. We don't mess with the central nervous system, and we don't have sympathetic block, and we have long durations of anesthesia because of this regional anesthesia. Now, there are certain questions which everybody would like to ask when we give renal anesthesia to children. Is it safe under general anesthesia? Because children are not amenable to giving blocks with needles prior to being put to sleep. So when they are put to sleep, is it safe to give them blocks? Is it safe to mess with their neuraxis? Is it safe to do work with their nerves, which in adult would be more safe? Yes, recent literature has shown that you can safely administer regional anesthesia to children under general anesthesia. The test dose for epidurals, which we use in adults, is no longer recommended in children. There is always a risk of compartment syndrome in children because they're so amenable to increase in volume and its side effects. But there is no current data which shows that it increases the risk of compartment syndrome when young children are being given the block. What major change has come in anesthesia monitoring? Anesthesia monitoring has been completely revolutionized. You can anesthetize your patient, hook him up to monitors, and sit outside the room and accurately monitor your patients. What has made this change? There's something which is known as signal extraction technology. Now, the standard pulse oximetry, which you are so familiar with, uses a ratio of transmitted pulsatile red and infrared light. What this signal extraction technology pulse oximetry has done is that it begins with the conventional red and infrared photoplethysmographic signals and then employs a constellation of advanced techniques, including radio frequency and light-shaded optical sensors, to have signal processing and then adaptively filter out all the data to give you an accurate estimate during times which the normal pulse oximetry was not giving you. That is, during low perfusion states and during movement. So this, with the kid moving around, with the kid becoming hypothermic, during transport, this actually gives you extremely accurate SpO2 measurements. This allows you to effectively monitor during motion. You realize how important that is when you're traveling and when the sick children are being transported from one part of the hospital to another. This is the only method that you can now monitor them. It's safe and it's effective. This is what the signal extraction technology monitor by Massimo looks like. There's another thing new which is known as pulse co-oximetry, which is actually the non-invasive evaluation of blood loss. Advanced signal processing algorithms and unique adaptive filters work together to detect hemoglobin non-invasively. This allows you to measure blood loss in the real time. It's totally non-invasive, it's extremely accurate, very small sensors are available for neonates, and this has revolutionized our management of blood loss in the theater. Other modalities of monitoring, such as non-invasive cardiac output monitoring, has become routine practice in advanced centers. Transcutaneous measurement of carbon dioxide is now complementary to blood sampling and capnography and has a huge role to play in procedural sedation. You talk about MRI suites, CT scans, you talk about bronchoscopies, where you have non-invasive monitoring of the pulse oximeter and the carbon dioxide without actually intubating the baby. This has really made it very, very safe. Anesthesia depth of monitoring, which was very popular in adults, is now validated for neonates and infants. Point of care ultrasound is another place where we're using ultrasound to monitor and measure changes in the lungs, in the cardiac system, in the gastric system, central nervous system, the eyes. Everywhere you're using point of care to evaluate the child at the bedside and optimize the anesthesia care. Anything new in pharmacology? Yes. Two drugs such as remimazole and articaine are drugs which are now safer, faster, and of a shorter duration, making anesthesia safe in children. Newer drug delivery systems are now the routine in children. Total intravenous anesthesia has been validated in adults, but we were very scared of using it in children because we were not sure of the pharmacology, also the pharmacokinetics and pharmacodynamics. But AI has revolutionized the delivery of drugs into the pediatric systems. Lastly, there are huge changes which have been brought about recently in the resuscitation protocol of children. Use of ECMO and extracorporeal pulmonary resuscitation is being recommended in children with changes such as myocarditis, erythema, heart block to prevent the onset of CA, cardiac arrest. Can you see how revolutionary this is? You're preventing the onset of cardiac arrest in children who are susceptible to develop so with the help of ECMO. Fluid resuscitation has undergone a change from the initial boluses which we were giving with 20 ml crystalloids to children. We've come down to cautious 50% reduction of 10 ml in refractory septic shock. Intra-arrest and post-arrest care has also changed. The guidelines have changed. They are all evidence-based. For those who do deal with children, they would make sense that respiratory rates have increased, cuff endotracheal tubes have found a place, cricoid pressure is no longer recommended to prevent aspiration. And in the post-operative period, we've shifted over from just the intraoperative or the cardiac arrest care at the time of arrest to enhancing the survival in the post-arrest period by incorporating a recovery link in the chain of survival. So to summarize, ERAS protocols, which were initially used in adults, are now being used in pediatric patients, in which fasting duration of only 1 hour is recommended in children. Para-oxygenation is the way to go to prevent apnea-induced hypoxemia in children. Advanced monitors like Masimo, NRIS, pulse contour analysis have been validated in children. Central neuraxial blocks have given way to peripheral nerve blocks. New drugs like remimazole and articaine are now finding a place in pediatric anesthesia. There are many studies which now conclusively show that anesthesia is safe for the developing brain of the small child, and recent guidelines which have been incorporated into the resuscitation protocol of children have been validated in literature. Thank you so much.
Thank you, Dr. Ranju Singh, for such a beautiful, informative, and very, very clear presentation. Can you and Dr. Tapaswini come forward for memento presentation? We are already running way back from our schedule. So after that we'll disperse for quick lunch and come back. So Dr. Tapaswini and Dr. Ranju, please come forward. And may I request Dr. Hansmukh Shah from BPO to give away the mementos, please, and honor our speakers.
Please don't.
Once more, please.